I'm Carrie, and I know a bunch of you. I work closely with a bunch of you. I am a diabetes educator, and I've been working with pumps for a number of years. I got my most practice when I was working in an endocrinology practice, and I would see many people every day with that, and we did a lot of problem solving. So I'm going to start here. I have a coworker, I would say, Rose Catanzaro, who's here, who I wanted to be here because Rose works very, very closely with the high-risk OB population. And she and I talk a lot about patients, but she works with detailed management of these high-risk pregnancies and knows about as much about insulin pump therapy as anybody can know, too. So she's a great resource. So insulin therapy, why do we have it? Basically, for our type 1s, they do not make any insulin. And in our type 2s, they need it. So in our type 2s and our type 1s, we are combining insulin and actually adding some metformin for some of our pregnant women as well to overcome insulin resistance. The insulin pump is ideal for very insulin-resistant individuals and for our type 1s who need full replacement of insulin. The insulin pumps came along in about the 60s, and the first insulin pump was about the size of a backpack. So it's come a long way, got smaller and smaller and smaller, and now they're actually working on the pump that is combined with the continuous glucose sensor, and they're working toward the artificial pancreas pump that will actually sense the glucose trends, the rates of falls and rises, and be able to adjust insulin delivery. But we have a ways to go with that. So the basal bolus concept just is really, really key. The basal insulin, which is what controls the blood sugar between meals overnight, it's about 50% of daily use. You'll see a lot of red flags when you get patients who come to you maybe on 80% basal, 10% bolus, 20% bolus. You know something may need to be adjusted. But with insulin, everything's got to be individualized. You'll see somebody who needs barely any basal and lots of bolus. So you really have to individualize. So the bolus insulin is for the meals and for correction. When you're doing sub-Q, you use like Lantus and then a rapid acting. With insulin pump therapy, we use only a rapid acting insulin. Sometimes we use U500 insulin, but it's not as malleable as a rapid acting insulin. So the real expert of insulin pump therapy has just walked in as well. So Dr. Mostello and Rose have really been working with pumps for a long time. They're fabulous resources. So normal daily plasma insulin profile would be you see these spikes in insulin after meals. When you use your analog and your long-acting insulin, you're giving the basal, and then you're delivering the bolus for meals. When you're using pumps, you can more finely tune, and I'll go over the benefits, but you can more finely tune the basal insulin delivery rather than your injection of Levi or Lantus. You can adjust the basal rate by time of day, and you can finely tune your boluses as well. So the benefits of how you deliver insulin for somebody with type 1 or type 2 diabetes is when people are on their fixed doses, and a lot of our pregnant women are put on NPH and BID, and then they're on fixed doses for their meals. They really have to eat at certain times. They benefit if they eat about the same amount at certain times. So they've got to fit themselves to the insulin dose. Now we like our people who are on pumps to also follow budgets for carbohydrates and try to have regularly spaced meals, especially when you're pregnant. We don't want you going too long between meals. We don't want you getting too high after meals. But you have much more flexibility in that if you do delay a meal, you simply don't bolus, you shouldn't drop. And if you are exercising, you can adjust an insulin pump. You can pull away basal to decrease the amount that you're getting. You don't always have to eat to when you're expending more energy. So there's more flexibility. There have been studies with pump continuous subcutaneous insulin infusion versus multiple daily injections. And these are people who are on NPH and Lispro. So that might be your pregnant women, perhaps, who are on the NPH and the Lispro as opposed to an insulin pump. But we can get lower A1Cs with the pumps. And you also see marked decrease in the amount of insulin that people require. We're really seeing this with the use of Levemir in our pregnant women, that they may be on 30 units of Levemir, and they're transitioned to a pump, and they need half that amount. The absorption is much better in the insulin pump. This is in pregnant women, yeah. This is general, yeah, this is general. But we've observed this. Whoops, my pumps didn't show up. Typically, I'll go into this later, when you're transitioning someone from subcutaneous injections to insulin pumps, you take maybe 80% of their total daily dose prior to being put on a pump. With the Levemir, we found that it's much less than that. So it's pretty remarkable. I'm not sure why my pictures aren't showing up. Oh, here we go. Okay, so these are just some of the brands of insulin pumps that are out there. Medtronic has been around for a long time. The t:slim is the newer one, touchscreen. The Accuset Spirit is an older one, actually it's an Accuset Combo now. I'll go through some of the pros and cons of these different pumps and how people decide what to use. When you're trying to fit a pump to a patient, there's different criteria to take into account. This one actually has been updated. The pods are smaller. In our pregnant women, we were finding that the pods were failing. So a woman may be out in the grocery store and her pod starts alarming and she's no longer getting insulin. And that key risk with an insulin pump is that if your pod fails, if your insulin is no longer being delivered, you don't have any basal insulin in your body. You're just getting a steady stream of the Humalog, the rapid-acting insulin. So if that is interrupted, you can develop diabetic ketoacidosis very quickly. So we have not used these Omnipods much in pregnancy recently, although I hear that the newer pods are doing really well and that people are really happy with a pump that doesn't have feed. And Medtronic Minimag now is updated, and it has it is integrated with a continuous glucose sensor. It's called the Enlight sensor, updated from its previous sensor. It is, you can program the pump so that if the sensor detects the sugar dropping below a certain level, the pump will suspend. So it's like they say it's a step toward the artificial pancreas. If the pump alarms and says threshold suspend, blood sugar 60, the patient has a choice to say keep going, I'm going to treat my low, or if they sleep through the alarm, the pump will restart in 2 hours. It will continue then, and then if the low continues, it will suspend again for 2 hours, and then it will continue. So they had to design it so that it wouldn't suspend completely because somebody would develop diabetic ketoacidosis. Now, we have some people who are having good luck with it. We have a woman who just delivered who was using the threshold suspend. I think we ended up having to turn off the threshold suspend, though, because she was getting false alarms. She wasn't really low. So it still has worked. The t:slim has cannula with it. So you have an infusion set, and I'll show you some infusion sets later. The Animal Pain and the Accuset Combo, the benefits of those pumps, they have remote bolus controllers. So the meter you don't have to pull out your pump to give yourself insulin. You can check your blood sugar with your meter, you put in your blood sugar, and it will remotely tell the pump to give you insulin. So that's a real benefit, especially for women. So basically the basics of the pump. They're external programmable pumps connected to an internal subcutaneous catheter. Some people think that it has to be surgically implanted. You know, it's just a substitute. The set may go in with a needle. It may be a needle. The pump reservoir or the pod may hold 150 or 300 units. So they have enough insulin. The Accu-Chek combo pump, you can use that for 6 days. The reservoir has 315 units max. The smaller mini-med only 150 units. So which pump you choose for a patient may have to do with how much insulin they use in a day. The infusion sets connect the reservoir of insulin to a cannula or a needle that sits in the subcutaneous tissue. And infusion set problem shooting is a big part of what we do in working with people. You shouldn't get occlusions. And if somebody is getting repeat occlusions, meaning their catheter is sinking, they're getting a site where they don't seem to be getting good insulin infusion, you want to problem solve and maybe try a different kind of infusion set. In pregnancy, we frequently use the angled cannulas, which are less likely to crimp. Many people who are on insulin pumps when they come to us are using sets that go in perpendicular to the skin, and those are the ones that are more likely to crimp. People who are really worried about, we have them use needle sets where it's a needle that stays in the subcutaneous tissue, and that doesn't have the risk of occluding. It can't crimp. So the pumps are battery operated. The when you charge it, just like a phone. You can charge it while you're driving. The others may have lithium batteries or alkaline batteries. Remote control features are benefits. But the basal is continuous and automatic. So sometimes we get people coming into the hospital and the insulin pump orders are put into the system, and the staff may think that they need to change the basal rate. If the basal rate is 1 unit per hour at midnight, it goes up to 1.5. They may think they need to come in and direct the patient to increase that basal rate. That's automatic. We program that to automatically change by time of day. The bolus is what is intermittent and it's user directed. So the patient says, okay, I'm going to give myself insulin now. The benefits of insulin pump therapy, there have been a number of studies, but the decrease in A1C may not be as marked. This is in an overall population. It does seem that there's decreased insulin variability, and the variability is highly related to nephropathy, retinopathy, the complications that you get from diabetes. In our pregnant women, I don't have a graph here, but I went through last year and picked out a number of our women who were on pumps, and their A1C was markedly decreased at the beginning of their pregnancies and the end of their pregnancies with insulin pumps. The basal insulin can be much better. We've had people requiring 300 units of insulin, and then we put them on a pump and we can half that amount of insulin that they need. Maybe they're getting 80 units of Lantus twice a day. We put them on a pump, and with 2 units an hour, their blood sugars are much better controlled. So the superiority of that basal infusion when it's trickling in is much better than giving a big bolus of this thick, viscous insulin. The benefits would be small increments for the very insulin sensitive. You can give a bolus of 1.025 units for a meal, and that can make a difference for somebody, or a basal rate of 0.025. We had one woman in the hospital who had renal impairment, and she required, before she came to us, she was on 7 units of Lantus a day. On the pump, we had her on 0.2 units of insulin per hour. So tiny, tiny amounts of insulin. And that kept her steady. I remember in the hospital, the nurses were really worried because her blood sugar would be 90 and she was refusing to eat, and the pump was going, and she stayed pretty stable at that point, 2 units per hour. So we can give very small amounts and we can give large amounts as well. I'll talk a little bit more about the pump calculator components, but it can protect people from giving too much insulin. Stacking is what can happen if I say I'm giving myself 2 units now, I'm giving myself 2 units in another hour, and I think I'll give myself 3 units more. I'm eating, and what can happen is I can eventually bottom out. The pumps have ways of protecting us, people from bottoming out. So the key risks of insulin pump therapy are the diabetic. The key risk is the diabetic ketoacidosis catheter treatment, and that can happen just with 2-3 hours after on a pump. In the hospital, you might see that people are come into the ICU. They might be on an insulin drip, and the drip may be stopped, and then 2 hours later they may start the insulin pump. In that short period of time, a person with type 1 diabetes, the blood sugar can go up markedly and even put them back into DKA. So iatrogenic DKA does happen in the hospital more than it really ought to. We see people who come into the emergency room with high blood sugars and not quite in DKA, and they don't get their insulin by the time they're on their floor. They need to, their blood sugars are really elevated. Site infections and infusion set care is really important. People have to change their set frequently, and the research has shown that every 2 days is a better frequency of change. We have software that we can use with all of the pumps that allow us to evaluate how frequently people are changing their sets. So it's one way to assess overall control. I know we've had people come into the hospital and I've been able to see that they didn't rewind their pumps for 2 weeks. So somebody who's very insulin sensitive can theoretically get away with not changing that site for a long period of time because they have enough insulin in their reservoir. But the site can get infected, and the infusion won't be as well, and the insulin can become less effective over time. t:slim is one of the pumps that has a temperature sensor in it, so that if that insulin does get too warm, they get an alert. And here in the summer, it can get pretty hot. Okay, so the basal insulin is automatic. There are studies that people need about 5 different basal rates, but that really changes by age. It's very pronounced in the teens and younger people that they might have a very, very pronounced dawn phenomenon. We had one pregnant woman, young 18-year-old, who came into the hospital, and she was on subcutaneous injections, and we were doing a lot of testing, and we downloaded her meter, and it was just remarkable. Between 3 a.m. and 7 a.m., the blood sugar just skyrocketed. With subcutaneous injections, it's really hard to address that, but with an insulin pump, you can crank up the overnight blood sugar basal rate. Typically, people need lower levels in the morning and then highest in the early morning hours. The first step to good control is establishing appropriate basal rates. So, testing the basal rate. When you first put somebody on an insulin pump, and what you have to remember is that these pumps, they're smart, but they arrive dumb. And how we program them, we make educated guesses when we say, well, let's try this. And sometimes we're spot on. A lot of times we're not, and they need to be adjusted. So people need to know, if I'm going to be put on a pump, this pump isn't going to do everything for me. If I want to get the most out of my pump, I'm going to have to work with my medical team. I'm going to have to do testing. I'm going to have to do monitoring. And we're going to have to make sure that these rates that we've got set in there are correct. So, testing basal rates, the criteria to start a test of a basal rate in a pump is that you directions associated with it. And we often will order that when somebody comes into a pump, an overnight basal test. So then we'll measure the blood sugar every 2 hours if it's during the day. If it's an overnight test, what we might do is have the person eat dinner, check the blood sugar an hour after dinner, no more food, check it at 10 p.m., midnight, 3 a.m., 7 a.m., and watch and see what the blood sugar does. And so if the blood sugars are going up, then we know that the basal rate is not high enough. If it's dropping, we know that the basal rate is too much, and then we can make adjustments. You can't just do one overnight basal test. You have to do a couple of them to really know what's going on. Once you get the overnight basal test correct, then you can start doing the basal test during the day. It's a lot of work, and it's hard sometimes to work with patients, asking them to delay their meals. We say delay your meal if you're pregnant. Don't skip your meal. If you're not pregnant, though, we say, well, why don't you wake up? Okay, we've got your fasting good. Let's say, wake up, don't eat your breakfast, and let's see what happens to your basal rate. Let's see what happens to your blood sugars. So if your blood sugars go up, the basal rate's not high enough. If they go down, it's too much. When you adjust the basal, though, you usually go back a couple of hours before you start to see the rise in the blood sugar. If you guys have anything to add about that, please do. The bolus insulin, the pump, is not automatic, so the user directs the pump to give the bolus of insulin. So the smart pumps have calculators that recommend bolus amounts based on how they've been programmed. So again, there are certain calculations that we use, and there are a number of different formulas, and different practitioners may have different factors or whatever that they use. You put that into the pump, but the only way to know if that's really correct is to have people do testing. Blood sugar monitoring, tell us what they're eating so we can see how their blood sugars respond to the recommended bolus. So the peak action of the bolus, 30 to 90 minutes after delivery. The timing of the bolus can be key. So if a blood sugar is really high before a meal, if somebody gives it earlier, that can help. If the blood sugar is right where it needs to be, giving it maybe 15 minutes before the meal is a good idea. But the key thing to know is that many people who are on insulin pumps aren't really using their bolus calculators because they may have never tested them and they weren't set up to work for them. John Walsh is sort of the guru of insulin pump therapy, and he's done a lot of research on, he's got a study of about 200 people with type 1 diabetes who were very, very well controlled. And he's done some analysis of what the formulas are to determine the appropriate calculations for their pump calculators and whatnot. And what he finds is that often prescribers will prescribe easy numbers. So it's easy to say, okay, let's just start them on 1 to 15 and 1 to 50. You know, because those are easy numbers. Or let's give them a carb ratio of 1 to 10, 1 to 40. That you would expect there to be a bell curve. You know, if you think about everybody needs a different weight, different insulin sensitivity, if you were to look at different carb factors and sensitivities and whatnot, how we program the bolus calculator, you would expect a bell curve. But in fact, what you see is that there are some numbers that are used much more frequently than others because they're easier for us to use. So it's just kind of a reminder that it's important to program the pumps, but then have people test them. So the bolus calculator components. So the insulin to carb ratio, 1 unit of insulin for every X grams of carbs, and the ratio may vary by time of day. It's frequent. We often see that people need more aggressive carb ratios in the morning. If they're very active in the middle of the day, maybe less aggressive carb ratio. sensitivity is the amount that 1 unit drops their blood sugar. So we have some people 1 unit drops from 100 points, other people 1 unit drops from 10 points. So the nice thing about our pumps is we can individualize to make it work for the person. But I've seen people in the hospital who were put on their pump and their correction was 1 to, I had a woman who was in recently and her correction was about 1 to 80. And so when I went to see her and I looked at her pump and I downloaded it and looked at the information, she was a very small woman and I saw that she was inputting into the bolus calculator that she was eating like 100 grams of carbohydrate. And I knew she wasn't eating that, so I asked her what she was doing. She was tricking the pump. She was getting the pump to recommend a bolus because when she told it her blood sugar, it didn't recommend enough insulin. So her way of working around that was to put in carbs that she really wasn't eating. And what often happened with that is she would bottom out. So I was able to see that in a 2-hour period, she was really frustrated. She was in the hospital. Her blood sugar was 300. She put in so many carbs that it gave her the total amount of insulin she usually gets in 24 hours. So we were able to, proactively start giving her food, and she, did require excessive amounts of carbs the rest of the afternoon to make up for what she had done. But people find ways to work around how their pumps have been programmed when they don't work for them. And what we like to do is say, let's make this work for you so you don't have to trick the pump. Let's make it so it recommends what you really need so that you can test it and reprogram this pump. So another example would be somebody whose pump is programmed 1 unit for every 15 grams of carbohydrate, and they know that if they're eating 45 grams and they take 3 units, their blood sugar gets really high. So they just always tell the pump that they're eating 90 grams of carbs instead of 45. So figuring out what people are really doing, they often have reasons for doing what they're doing, but we want them to get the pump to work for them and to not have to trick it. Target blood sugar is the goal for the prenatal blood sugar. We use it together with sensitivity. So depending on who your patient is, if it's somebody who you want really tight, who needs very tight control, we may have a target of 90 plus or minus 20. So some of our patients on Animas pumps have blood sugars where the target is very low. The pump, other people might have a higher target. We say 100 to 120, in which case the blood sugar would be corrected down to the middle of that target. One thing to know is that bolus calculators in pumps are very different. They don't all work the same. So you have to know your pump and know how it's going to give a person insulin. So for example, a Medtronic pump, you put in a target of 100 to 150, and the correction was 50 when the unit drops to 50 points. If their blood sugar was 200, it would deliver down to 150, which is 1 unit. Whereas if it was an Animas pump and the target was, what did we make it? If it was 100 to 130, the Animas pump would correct the person down to the middle of that target, 115. So bolus calculators work differently. One pump, I'll get to the other thing here. The duration of insulin action is another thing that differs in pumps. But this is, if I give a bolus, how long does that bolus last in my body? So if you have a continuous glucose monitor, you can actually see if you've already established that your basal rates are correct. That person can be on their pump and they cannot eat and their blood sugars don't drop or fall. You've got the basals figured out. If they give a bolus, you should be able to see the blood sugars do this and do this. So when they kind of even out, that would be the duration of insulin action. So sensors can help us a lot determine that. It's the combo that doesn't take into account the bolus for the carbs for that curve, whereas the other pumps will take into account the carbs and the blood sugar. It's complicated. I have a cheat sheet that I have to pull out, and Rose and I are working on getting all these specifics of the pumps. So bolus calculators are not all equal. We do have some additional features with the Accu-Chek combo when we set up the bolus calculator, and it takes a while to wrap your mind around how it works. I don't know how you're finding it with Jessica, but you can set, if my blood sugar, you can set a meal rise. So we have women check their blood sugar an hour after they eat when they're pregnant. So with the Accu-Chek combo pump, we say that a 50-point meal rise is acceptable. We're going to accept that. So if they're 100 and they go up to 150, that's okay. So if their target is 100 and it's an hour after their meal and they're 150, the Accu-Chek combo, if we set that meal rise to 50, won't recommend anything. It's going to say, look, they've gone up 50 points, we accept that. But you can accept how high that blood sugar can go after a meal before you will recommend a correction. So if the blood sugar were 180, it went from 100 to 180, it would correct only down to 150. So it's a protection from getting too much insulin. But then you can also give a snack size whereby if somebody eats something more, it doesn't continue to, it won't continue to subtract insulin from a high blood sugar after a meal. It will allow that person to get that much carbohydrate in. So a more insulin resistant person can have a larger snack size before that algorithm is started. Target, I've got a little bit on target. Subtractions for insulin on board. So let's say we used to have a pump that would tell people you need to eat, and you need to eat this many grams. So let's say I just gave a bolus of 10 units, and it's a half hour after I've eaten, and my blood sugar is 200. My sensitivity is 50. This is a little complicated, okay? So I would normally get 2 units to correct my blood sugar, but I've still got maybe at least 6 units, 7 units in my system from the bolus I just gave. The Cosmo pump would say, well, if you've got 6 units and we know that 1 unit covers 15 grams, you need to eat 75 grams or you're going to bottom out. Okay, so it would recommend that people eat. The pumps that we have now don't do that, but they will not give you insulin if you have too much insulin on board from a previous bolus. And some pumps will subtract from the carbohydrate grams, and others will not. So if my patient on an Animas pump has a blood sugar of 70 and they're eating carbohydrates, they still have insulin on board. They'll get the full amount for their carbohydrates. But if they're 69s or below their target, they'll get 0 for their carbohydrates. So those are just some of the nuances that make it complicated when we're trying to figure out how do we make adjustments in this person's insulin pump calculator settings.
Explanation for offset time.
Offset time is the time, it's the, Rose, can you help me with that? It's the period of time for the meal rise, that it takes into account the meal rise. So that 50-point meal rise, so if it's 1 hour, after that it's gonna correct you down to a lower number. So it's the amount of time when it won't correct below the meal rise. Okay? And then the algorithm starts to go down, so if it's an hour offset time, it's like a block, and then it starts going down, so if my blood sugar's high, it's going to correct me down to here as opposed to here. It's really complicated. I think I've worked with so many different insulin pumps, and the Accu-Chek combo pump, I think I spent 10 hours on it trying to get my mind around it. It's not as easy as the other pumps. Okay, getting the bolus amount right. There have been studies done on accuracy with carb counting. I just got the CPT newsletter from Omnipod that said with adolescents, some of them have like a 30% accuracy with their carb counting. Adults, it's also like 60%, so there can be huge errors in carb counts. To really get your carb count right, you have to weigh and measure. And getting back to that once in a while, there are scales you can get you actually weigh the food and you put in the code for the food and it will give you the carb count for that food. There are carb factors where you know, like an apple is 0.3% carbohydrate, so you weigh it and then you multiply it by that. But weighing and measuring, reading labels is really important. One tip that John Walsh will give is that really smart pump users override the bolus recommendations at least 10% of the time because they know more than the pump. They know, well, you know, this meal is a little bit higher fat. This one has a little higher glycemic index. So I'm going to adjust my bolus a little bit. They know that they're going to exercise maybe after their meal, so they may decrease their bolus. Advanced bolus techniques, I know that you use them a lot over in Salutaire. There are a number of women who will use a dual wave bolus or a combo bolus. So when you're giving injections, if you need 5 units per your meal, you give 5 units. With our pumps, we can say, I need 5 units for this food, but I want to give 60% right away. And then I want to give 40% over the next 4 hours. Maybe it's a food that's slower to digest, so a combo bolus can be a way to do it. Combo boluses are something that can help people who have gastroparesis, who may, if they bolus right before their meal, they bottom out. But if they give just a little bit and then they give the rest over 3-4 hours, they don't bottom out. What other things? Oh yeah, the feedback from the CGM can be really, really helpful for the person who doesn't know when that glucose is going to enter the bloodstream. They can actually wait to see where they start to get the up arrows, and then they can get their bolus. Many people need different carb ratios at different times of day. One advantage of the Accu-Chek combo pump is you can have preset boluses. So all of the pumps, you can do temporary boluses. You can basals. You can say, today I am going to be doing yard work all day. I'm going to be really active. I don't need as much basal insulin. So you can tell the pump, give me 80% of my basal rate for 4 hours, 5 hours. Okay, all of the pumps you can do that. But the Accu-Chek combo pump, you can also set a bolus for pre-menses, or you can set a bolus for extreme exercise, that's 25% less. Or you can set a bolus for sickness, it's 25% more. So you can also adjust the bolus calculator components to give more or less depending on your health status, your menses, whatnot. Yeah, those were these are just some pearls from John Walsh that I was talking about, that you expect pumpers to not always do everything the pump tells them to, and that pump autopsies show that medical providers use easy numbers, so just keep that in mind, because I know that I do that with people. 1 to 10 is going to be easier for you, I know that. Pump tune-up is really important. If you get people who come to you on pumps, how do you know if a pump is working? When you go to bed with your blood sugar 100 and be assured that you're going to wake up and you're going to be about 90 or 70 or 90 or 70 or 80, you're not going to drop. Do you have the confidence to know that you can go to sleep and not bottom out? That's a sign of successful pumping. Can I delay or skip my meals and not get high or low? That's your daytime basal test. Do I give my boluses after meals and I don't get too high and I don't bottom out 3 hours later or 4 hours later? Can I give my correction bolus and not bottom out after I give that? Is my duration of insulin action correct? One thing about that duration of insulin action is a very sensitive person, a bolus might last you 6 hours. So our woman with renal impairment, her duration of insulin action was set to 6.5 hours. She could give her bolus and she could bottom out hours later. Some of our pregnant women at the end of their 3rd trimester, they've got a duration of insulin action at 2 hours. So it varies a lot how long that insulin lasts in your body. Are you getting lots of lows? Are you over-treating the lows? Are you yo-yoing? Can when you exercise. A real test of your insulin pump is if you can do your exercise and not bottom out, if you've got an understanding of how to control your blood sugars. And it takes work. So this is just an illustration of how to test the correction factor. And I can't say enough how important it is that people do this test. If you give your correction bolus, and you haven't had a bolus in the last 5 hours, your card in the last 2 hours, by 5 hours after that, you should be back to your target. If you're here, and that's what we see a lot, you give your correction that doesn't touch you, we know that's not an aggressive enough number. If you go from here to here, we know your correction is too much. Teasing out what's the problem is always the challenge. It's like doing Sudoku. Is that how you say it? Sudoku? It's like doing a crossword puzzle, figuring out what component you need to change. Is it the carb ratio? Is it the correction? Is it the duration of insulin action? Testing the carb factor. This is where it's really hard to get the control in pregnancy. When you have type 1 diabetes, not only do you not make insulin, but you also don't make amylin. So that means that after a meal, you also have glucose from your liver, so blood sugars go up too high. And if you're not pregnant, you could use amylin, which can blunt that input of glucose, but you can't do that in pregnancy. And we want those numbers to be below 130, so the risks for lows out here, getting that carb factor aggressive enough that you're not too high 1 hour out, that you don't bottom out 3 hours out, is really tricky for patients. So anyway, testing the carb bolus by about 5 hours after you are back down to where you started. Do you guys have any comments about that? No? Yeah. So programming the pumps, the educated guesses. There are some hospitals that have algorithms, and I'm kind of thinking it would be helpful for us to develop something. It's not uncommon that we get calls about setting up postpartum doses for people. But anyways, they're educated guesses, and they're different organizations that set recommended amounts. So maybe if you've got somebody you're just starting to pump, first trimester might be 0.4 to 0.55 units per kilogram, 0.9 to 1 units per kilogram, postpartum less than that. You have to individualize the pumps. These two people will help you. Animas dosing techniques. I have a formula from Animas where they've done extensive research. They've compiled, the research from many different organizations: American Diabetes Association, Jovanovich, Peterson, Walsh, pumping insulin, and they've come up with recommendations for starting pumps for pregnant patients, type 1, type 2. One method might be going with how much insulin they're getting before they're pregnant, their total daily dose, taking maybe 80% of that. Another method might be looking at a number of units per kilogram, and then compare perhaps the total daily dose with the weight-based formula, and you see which is less, and you might take the less. But then you also have to take into account, is this someone who's coming to me with highly uncontrolled blood sugars? What we do see frequently with our type 1 women who come to us, though, is they may be on huge doses that they tell you your patients are taking, but they're not taking them. So a lot of our type 1s deliver, or before they come to us, they're no longer with, maybe they're a little bit older than 18, so they're no longer followed by Cardinal Glennon or by Barnes. They're now taking 40 units of Lantus, and they're supposed to take 10 units before meals. They're really not doing that, because if they do, they would be bottoming out. So we kind of have to start from scratch. How much are you really taking? And sometimes we need to go back to the basics with that to figure out what to do. But anyways, there are guidelines for how to start the pumps. Animas actually has a pump calculator for where you can put in the amount of Lantus, the person's weight, and it helps you come up with recommended compiling all the different formulas that have been contrived. So one thing that we know is usually that basal is approximately 50% of the total daily dose. But if a person's not eating very many carbs, it may be higher than that. Some individuals don't require as much basal. But I know that you see so much when you download pumps. One of our pregnant patients who was out at DePaul would come in repeatedly in DKA, and I'm not sure what was going on. But when we downloaded her pump, we were able to see that she was basically not getting any bolus insulin. Her entire insulin was coming from her basal insulin. And she was not a light person. She was clearly eating. So her basal were clearly much too high. And her blood sugars weren't totally out of control. So the thing was her basal was basically covering her boluses, and there needed to be significant changes in that. Carb ratios are different formulas we use when we put people on pumps. Maybe if someone's really sensitive, we do 500 divided by the total daily dose. If they're really resistant, it might be 300 divided by the total daily dose if we're starting from scratch. But again, the real way to see is by having people monitor. You give them a carb ratio, you look and you see what happens. John Walsh is really big on total daily dose and getting that total daily dose right and looking at the components. Sensitivity, I think we use this one most commonly in pregnancy, right? This would be more resistant. 1960s were very sensitive. This is the number that came from the study of about 200 very, very well controlled type 1 patients. This is the sensitivity that works for them. Not very aggressive. The duration of insulin action, I've already spoken about that. Maximizing the benefits, logs, blood sugar testing. You always go to eliminate the lows first, because if people are having a lot of lows, you're going to get your highs that come after that. The software can help a lot. Test those fat basal rates, get your fasting to goal first. Test the carb ratios and sensitivity. Observe and adjust duration of insulin action. Timing and the type of insulin bolus. Avoiding the stacking, and that's something I know we work on a lot with our patients who just want to eat, and it's so hard to know what needs to be adjusted if they can't consolidate their meals into discrete packages. I don't know if you can see this, but I don't think it shows up very well. But what you see here is a log of somebody who was keeping really good logs, really detailed logs that we were working on. And we could see a lot from this. But this is the kind of work we do. You've got to get the overnight right first. But here we know she was, the blood sugar, 167 minutes, inadequate correction. She corrected, didn't eat any carbs, and she was high in the morning. This is midnight. This is like 6 a.m. Here's somebody who ate yogurt. She went from 180 to 36 grams. She gave this minute. She went to 309. So do we see that happening a lot? Here we see someone, after her lunch, she goes from 163 to 211, which isn't a huge increase. But then over the course of the afternoon, she goes up to 246. So maybe that afternoon basal is going up. But you have to interview the patient because maybe she had something to eat in the middle of the afternoon, and that's why it went up. Here again, someone eats, they give their bolus, they go up to 409. So are they carb correcting? Are they doing accurate carb counts? Is that carb ratio not enough? But this is the kind of information we need to get. Here's somebody who's 136 before, 108 after, and then they go up to 188. Maybe they've got some kind of delayed absorption that's going on. This is the kind of thing that Rose and Dr. Mostello and Dr. Mara, whatnot, review in depth every Tuesday to late. This is just to show the benefits of the continuous glucose monitor. This is a patient who, you can see, this is the night, and here's the morning. She was clearly dropping overnight, so her basals were clearly too high. Okay? And then she was actually not getting her bolus for the breakfast. We were able to see that. She was going through a period, she was developing renal failure and getting more lows, and so fearful of giving insulin. And the continuous glucose monitor gave us a little bit of information. So deciding which pump to put a patient on, that's why knowing the pump can be helpful. Sometimes it's cost. I know that Roche has a very good financial program, so we just put a patient on Accu-Chek combo pump. The basal increment. So if somebody is very, very sensitive, the Animas pump you can get 0.025 units per hour. That's the smallest increment. Medtronic, you can do that as well. For our pregnant women who are insulin resistant, an Animas pump, the most aggressive carb ratio is 1 to 3. Whereas a Medtronic, you can go down to 1 to 1. And the Accu-Chek combo pump, you can even get more aggressive than that. You can have like half a unit per carb or something. You get very, very insulin resistant patients. All of the pumps, though, have maximum boluses of 25 to 35 units. And some of our patients need more than that, so they have to remember to go back in and give the rest of a bolus if they can't get the full one out in one bolus. The basals, though, can go up very, very high. So we had the patient who came in who was on almost 2,000 units of insulin at one point. She had basal rates about 4 or 5 at one point, very, very high per hour before she came into the hospital and everything. Infusion set options, totally daily dose, the size of the reservoir. The infusion set options, Medtronics are proprietary. All the other pumps include their infusion set. Some of the sets have inserters. It is not uncommon that you encounter people who are dreadfully fearful of sticks, and inserters can help because they're basically, you don't have to see the needle going in. Other people are just fine taking their angled infusion set and putting it in. They don't have any problems. But the inserters help some people. But if people are having occlusions, they need to reevaluate where they're giving, where are they rotating their set, which set are they using. Customer support's a big thing. If you call and you can't get a hold of anybody, that's a big thing. We have really good customer support from some of our companies and other companies. You can be on hold for a long time, and if you're panicked about your pump, you want to be able to talk to somebody right away. That just brings up one thing that I didn't talk about. All people on pumps should have backup plans. So they should understand their settings, and they should carry with them an extra infusion set. So I had a woman who was at work at KFC, and her infusion set came out. She wasn't going to be home. She had to work the rest of the day. She wasn't getting any insulin. She developed PKA. So you have to carry an extra infusion set. You should always have a syringe and some insulin so you can give insulin if you need it. You should know the 1-800 number for customer service. If you're going to be off your pump more than 2 hours, you really need to have a backup plan. We do have some people who are going to be off for even an hour. You could give half of the missed basal. So someone who's on 2 units an hour, if they're off for an hour, they're going to miss 2 units of insulin and the blood sugars can go up. And studies have shown that even in the 30 minutes that people disconnect their pumps for showers, you get an increase in the basal. So it's not a bad idea to maybe give half of that basal that you're going to miss before you disconnect, and then the other half after you connect, so you don't miss that basal rate. But people should know, okay, if my basal adds up to about 20 units a day, if my pump fails, I'm going to give 20 units of Levemir or Lantus, and then I'm going to know my carb ratios and my sensitivity has disability. We have a woman who's blind who's we're applying for the T-Slim, which is brighter. You can see that. The Animas pain pump is very bright. Also, and it also has topical button pushes that you can memorize. Three things to get around you. Reminders, waterproofing, skinny, tubeless, Omnipod has got a program they call Cut the Cord, where they are encouraging people to go away from the tubing and go to the tubeless pump. Meter remotes are great for women in particular, and the integration with CGM, whether or not people are going to want that, so the Medtronic has the integrated CGM, but there's the Dexcom, which I find that people have much more confidence in, is not integrated yet with an insulin pump. It is to be integrated with the Animas. It's called the Vive, and it's out in Europe, and it's also out in Canada. That's coming out, but I know people who are using the T-Slim and the Dexcom, and they actually prefer having the units separated because they can keep their T-Slim, their continuous glucose monitor in their pocket, pull it out, and keep their pumps on their body, not have to pull it out to see what's going on. And especially for women, a lot of women will wear their pumps inside their clothing. Which infusion set, the length of the cannula, whether it's angled, whether it's a needle. Which patient? So this is a big one, and I appreciate anyone's comments about it. But type 1, there just are benefits. If you don't make insulin, and you're insulin sensitive, if you're giving even 1 unit boluses, if you can only do 1 or 2 or 3 with a pen, it's not going to be as closely matched to your true physiological needs. You know, maybe you only need 1.2 units, 1.3 units. Pregnant, type 1 or type 2 are great candidates for insulin pumps. One comment just about those patients who come to clinic who don't bring any records. Are they pump candidates? I think there are mixed thoughts about that. One thing that we're grateful for is if they didn't keep records and they were on sub-Q injections, we would have no idea what their total daily weight was. But at least with a pump, we can download it and see how much insulin they're getting, if they're getting boluses, if they're putting in their blood sugars. We can get more information than we can. They're entirely black boxes if they're on sub-Q. We don't really know what they're getting. I have one woman who I've been working with for about 6 months who was coming in almost every other week to DKA. She's a 30-year-old who has extreme fear of needle stick. And when she's with me, it takes her about 5 minutes to check her blood sugar. And to give an injection, it takes her a very long time. But would she be a good candidate for a pump? If she's so fearful of injections and she's getting DKA so regularly, might it be a better idea to put her on a pump where it's once every 6 days? I don't know. Those are the kinds of things we have to think about. Renal disease, you just can't give as little, small amounts of insulin with Lantus and Levemir when people require so little insulin. People really should monitor, though. If you don't monitor your blood sugar and you get a site occlusion, you can develop diabetic ketoacidosis. Another thought about when people change their sets, we recommend they change their sets before a meal, bolus, check after the meal. Don't change your set at bedtime because if you get a bad site, you can wake up and DKA. This is the best kind of person for a pump, is someone who's going to work with the medical team, who's going to follow up and backfill logs. But do they have to be an expert at card counting? This is one of the arguments I hear a lot. They're not really good at card counting, so I don't think they should be on a pump. Are they any better on sub-Q injections if they can't card count? I don't think so. So I think that we can still have people, okay, you take 4 units before a meal, the absorption is still going to be better and you're going to have a better rate of infusion with an insulin pump. Do they have to be smart to use a pump? Little kids use pumps. They're not complicated. using the more sophisticated parts of a pump requires some kind of analytical abilities. But if you've got a team you're working with, you can make it more confusing for people who are not very advanced. There's just an example of how an infusion set works. This one has a inserter, but this one, this is the active one. You just pop it in the body, get it straight in. So that's the one that we often don't use in pregnancy because it's there's an insertion site, so people disconnect before their showers, before their swim. Any questions?
I was hoping you could, you were the one who talked to me about the concept of people goals.
Oh, yeah.
And for a fellow, because we do need someone to do that with someone.
Right. So, especially with the pregnant women, where you really want that tight postprandial control. If you make the bolus so aggressive that they're not high an hour after a meal, you have that risk of them bottoming out later on. So the super bolus, and I think you guys use it a lot, you pull away the basal. So if they're getting 1 unit an hour at the time of their breakfast, you take away that basal and you add it to the bolus. So they're still having a less aggressive carb ratio, maybe 1 to 7 is what works for them, but you're adding 2 units to that, and you temporarily, you can either actually program, if somebody eats breakfast at a certain time, you can markedly decrease that basal and add it back to the bolus within a higher carb ratio. You want to explain that any differently?
No, I think that's good. The important thing is if we build it in, we have to
Or else,
then I request it a lot.
yeah, you can temporarily set a basal and not give any 0% basal for several hours, and then add that basal amount to the bolus. So if I calculate or recommend that I take 5 units on the meal, I'm going to add 2 units to the second, and that gives me total 14. Oh no, because again, that whole issue of amylin is a big problem with people with type 1 diabetes, and you get very high after meal blood sugars. And a lot of people don't want to take Similac, which is an additional shot. And so they get those highs after meals, and if they increase the carb ratio, they bottom out afterwards. So using the super bolus, Gary Tobin actually uses it a lot at Wash U with his patients, and that's where I first heard about it in that group. Yeah. Yeah, we've got.
It's mainly acute care that do it, but it's focusing on.
But I highly recommend if anybody is really interested in insulin pumping, this is a fabulous book. John Wall, Pumping Insulin. He just walks through all the things you have to do to successfully use an insulin. This guy's had diabetes for 50 years, and so he loves to do the numbers and how to figure out what works. So he's got all kinds of tables for initiating insulin, if you're having frequent highs, if you're having frequent lows, how to go about making adjustments, increments based on total daily dose for adjusting basal. Someone who's not getting, who's got a total daily dose of 30 units a day, maybe we adjust the insulin 0.5 increments, whereas someone who's getting 60 units a day, 0.1 or 0.15 or something like that. The amount that you increase the basal.
I was not aware of that problem. I'll get it from Summer's library. I apologize for because I only have half dated one, and I was looking
services, and he actually runs the service. Everyone who works for the service has type 1 diabetes, but they do troubleshooting insulin pump control. They have great tools for evaluating your glycemic control. One thing that the pregnant women really like is a website called Diabetic Danica, and some of your patients are the ones who told me about it. And Diabetic Danica is a college student who wears an insulin pump who posts all kinds of YouTube videos about wearing a pump. And I know people who've gone there, it's like, okay, which pump do I choose? And she'll be standing there with her friend, and she's unanimous, and her friend's is a Medtronic, and they'll go through the comparisons. And then they'll do one on where do I wear my pump? And they'll talk about all the little places that they pump their pumps and, pockets they sell in their clothes. So there are a lot of great resources online for insulin pumpers. So, all right. Well, thank you for inviting me.